Folks, we're going to give people a couple minutes to join and we'll get started soon. Why don't we get started, and I can go through some initial announcements as people are joining, so I can get to the meat of today's meeting and everybody can participate and enjoy that. Good afternoon. My name is Susan Poland. I'm the Associate Executive Director for Public Affairs and Advocacy at APHA. It is my pleasure to welcome you to the June meeting of the Alliance. Today's meeting, we're joined by Dr. Mike Osterholm from CIDRAP, and I'll be talking a little bit more about Mike in just a couple minutes. But before we get into today's discussion, we have some quick updates that we want to highlight since we last met. I'm sure we all know that CDC has a new director, and she will be starting soon, Dr. Mandy Cohn. And also earlier this month, the president signed the Fiscal Responsibility Act of 2023. There's a lot that is good about having that legislation signed, although we are seeing some repercussions for our work to protect and promote the public's health. Some of the COVID funding has been rescinded and the budgets for federal agencies will be capped. So we're looking to see the implications of that as we move forward. I want to just take a note of personal privilege and thank all of you who participated in the Policy Action Institute last week. And I see that Dr. Lisa Simpson is here, and thank Lisa as our partner in the PAI for the last 5 years. It was a successful meeting. We had close to, well, over 300 people in the room, and the numbers of people who are watching virtually varied from 150 to somewhere around close to 200. So there were a number of people who were really engaged in this. And yes, I think that I agree, Lisa, the panelists were great. They came together really well and we had some fascinating conversations. But one of the things that was consistent throughout was that the public health system and infrastructure really needs to be shored up, that there are a lot of traditional and non-traditional partners who are willing and interested in doing that, recognizing the implications for everybody's work. But probably even more importantly, we need to figure out how to talk about it and talk about it in a way that makes it compelling, not just those of us who work in this area day to day, but also those who are making decisions related to policy and communications. So more to come on that, but it did align really nicely with a lot of the work of the Alliance, which is really nice to see. Just a quick update, 2 meetings that the Alliance will be at and that we hope you'll be joining: the NACCHO annual conference in July. And we will be at that meeting, as well as our annual meeting, which is a little bit later this year, starting on November 12th. It'll be in Atlanta. And early bird registration has opened, so we hope that you will plan to join us in Atlanta in November. A quick note to meet our summer 2023 practicum student and intern. I suspect that you will be hearing from them in some way, shape, or form. If you were at the Policy Action Institute, you had a chance to at least see Aisha and Sarah last week. So Aisha is joining us for a practicum from Baylor University. She's working on an MPH in community health, and Sarah is working on her Bachelor's of Science in Public Health at GW, where she's double minoring in health equity and human services and social justice. So welcome to both of you. And again, I look forward to working with you, and I'm sure other people will be looking forward to working with you throughout the summer as well. Now let's get into the gist of the meeting. And he told me that I can just say, here's Mike, but I think he deserves a little bit more than that. So we're going to talk today about the COVID crisis group lessons from the COVID ward investigative report. And this report was put together with support from 4 foundations, formed from a group of 34 experts. Originally, the decision or the hope was to plan a national commission focusing on issues from the pandemic, but unfortunately, that does not look like it's going to happen. Mike has been actively involved in that, and so we're lucky to hear from him today. He's a Regents Professor, McKnight Presidential Endowed Chair in Public Health, and the Director of the Center for Infectious Disease Research and Policy at the University of Minnesota. Where for your information, it is 95 degrees today, so climate change is real, and they're experiencing it in Minnesota. In November 2020, Dr. Osterholm was appointed to the COVID-19 Transition Advisory Board, and he served as a science envoy for health security on behalf of the U.S. Department of State from June of 2018 through May of 2019. He's the author of 2 New York Times bestselling books, Living Terrors, What American Needs to Know to Survive the Coming Bioterrorist Catastrophe, and Deadliest Enemy, A War Against Killer Germs, and has written over 350 papers and abstracts on the topic of epidemiology and infectious disease. So with that, here's Mike.
Well, thank you very much, Susan, for that very kind introduction. And I just want to thank all of you for being here today. This is a somewhat intimidating situation to speak to this group about this topic, because you're all experts. You've lived through COVID. You've been there. You've been on the front lines. And so in some ways, this is not like the expert coming in and sharing wisdom and knowledge with you all. You all have lived it and dealt with it. So from that perspective, I hope that my comments, if nothing else, offer another opportunity to think about what happened and what we can do so that when the next pandemic hits, it won't hopefully be quite the way that this one did. I would remind all of you that our group at University of Minnesota, CIDRAP, actually has been very involved with vaccine roadmap for coronavirus vaccines. And we've been very involved with the overall coronavirus issue. I was part of the US government response in 2003 to SARS. In 2012, I actually spent time in the Arabian Peninsula working on MERS. And then 2015, was involved with the outbreak investigation in Samsung Medical Center in Seoul, Korea, when a MERS infected individual came back from the Arabian Peninsula to Seoul. So kind of have been there from the get-go. I'm sharing this as context. In 2019, on December 30th, our center, which has a very active news team, actually picked up on the chatter that was happening in China, and actually did our first story on what was happening in Wuhan on December 31st of 2019, long before most media and others really even recognized it was a potential situation. On January 20th of 2020, we actually put out a statement saying this would be the cause of the next pandemic. And as part of that situation, laid out why we had to move quickly to be better prepared, not fully prepared for this pandemic. And I must say it was of interest, because at that time, the feedback that I got was in our center was largely from my colleagues about, you're scaring the hell out of people. Don't do that. This is not, this is not going to be the case. The week after that, January 20th statement, I went to the Journal of American Medical Association and to their editorial leadership and said, could I do a perspectives piece on why we have to quickly mount our response to this incoming pandemic? Not only did they say no, but the week after that, they put up a full-page cartoon in the journal, which one column were all the reasons why seasonal influenza was the real problem and all the reasons why COVID was not, and that we should not take our eye off the ball of influenza. I tell you this story only because I think that it first of all, we have to recognize that preparedness in of itself is having a prepared mind to understand what might be coming. And when do you understand that those hoofbeats are zebras and when are they horses? And how do you respond? In the early March of 2020, I put out a statement in media that said that I thought that we could easily see 800,000 deaths in the next 18 months. Again, that was not well received. And unfortunately, 18 months later, we hit our 800,000th death. And it wasn't about the number of deaths that for me was the most important point of that. It was the fact that this was going to go on for at least 18 months or more. And many people came into this with the idea that, this is going to be like a hurricane or a tornado or seasonal flu even, where, you get a few bad weeks and then you move on and get done. And I think that one of the lessons we learned with this was the 3-year time period for which this pandemic really has played out, has had tremendous impact in of itself of what can be done, how can it be done, what do we know and not know. And so I think that that's it. Let me make one other point about what I think, then I'll get into the report itself, is the fact that we were not well prepared as public health or the medical community, and surely our national political leaders, to understand that this pandemic would change with time. And what was correct and right information on a given month in the pandemic could look very different just several months later. And not because somehow the science changed, it's because the virus changed. And when we saw the evolution of this coronavirus go from the Wuhan strain in that first year, looking at the subvariants that occurred or the variants and being told, well, these are just like rings on a tree. They're just telling you how old the virus is. And it wasn't until the end of 2020 when we saw Alpha emerge in Europe that we realized, no, that's not true. These changes have tremendous implications for transmission, for infectiousness overall, for serious illness, etc. And as such, what we watched was, in a sense, a series of pandemics overlaid on each other as new viruses emerged, or new virus variants, and what that meant. Let me give you just one classic example, and then we'll move on to the report. Schools. Schools are, I think, have been the most misunderstood issue in the entire pandemic in terms of risk. If you look at the first year of activity in this country, 2020, there was very limited evidence of widespread transmission in kids or serious illness, and yet we closed down schools. And people said, you didn't need to do that. The kids are okay. They're not doing poorly at all. Well, that changed dramatically with the emergence of Alpha. And if you just look, for example, there were 1,486 kids in this country, 17 years of age or younger, who died of COVID, that is recorded. If you look in the first year, it was 199 in 2020. In 2021, there was 609. And in 2022, there were 678. Fully 87% of the kids who died from COVID died in the second and third year of the pandemic, not the first year. And yet we use the data from the first year to inform us about what the risk was with kids, not realizing that things had changed. And that schools were now becoming a very major issue. And there was a really wonderfully comprehensive paper published several weeks ago out of a group in Boston, looking at those family members who wore thermal related clothes so they could monitor temperatures. And in those households, they found that, and this is with many thousands of participants, that in 70% of the time, the introduction of the virus into a household occurred because of a school-aged child, and then spread to the rest of the family. And so I only point these things out because if I leave you with no other point today, we surely could have done much better in many regards. But we also have to understand about an open mind. And the next time a pandemic like this happens, and there will be more, we have to come in with one of the lessons learned is, number one, it's going to last potentially a long time. This might not be over with in 2 or 3 years. And I think that some of us were somewhat, you might say, spoiled by the 2009 H1N1 pandemic, that most people saw it only as a spring peak in 2009 and then a big fall peak in 2009. But in fact, we actually saw peaks also in 2010 that just people didn't even think about as part of that pandemic. If you go back and look at 1918 influenza pandemic, 1918 was a bad year, but 1919 and 2020 had 4 additional major peaks of cases that in the long run contributed much more than even the 2018 or the 1918 cases did. And so as we talk about this report, one of the things that's going to be really critical is understanding that in a pandemic, things will change. And it will change not because we didn't understand or make, because, we weren't good enough to see the data we should have seen. It's because the virus will change as it evolves, and it very well could mean big changes for what we are up against. So what did this report come up with? I was one of 34 people who were brought in to work on this issue. I will say up front, it was a monumental task, and I give great credit to those who put this report together. I will also say that anytime you have 34 different experts brought together, don't count on consensus, okay? So not every point in this report was agreed to by every person who was on there. But I think the general sense is that one, we could have done much, much better in terms of this report, because I think that it really, to me, reflected the fact that we have to be prepared for people in the policy world, people in the public not agreeing or understanding. So I'm going to use an example. I, for one, when Omicron hit in November, December into January, February of 2022 and 2021, 2022, said, well, you know what? We may need snow days in our schools. And why? Not because it was just about disease transmission prevention. It was the fact that we had 40 to 60% of the faculty and staff out. How do you run a school when nobody's there? But we were so bound determined to keep the schools open, we weren't looking at the obvious issue right in front of us. And that is, we may need 2 or 3 weeks off. We're not talking about lockdowns that last 6 months. We're talking about how do you get through there. And I think that one of the things that we have to do in the future is prepare our leaders for this type of activity, and that lay out the fact that we may see changes come, and that's expected. And I think that's a very, very important point for us to come away with. The second thing is that we all know that public health as an institution in this country, particularly state and local health departments, was not built for this kind of a situation. I spent 24 years at the Minnesota Department of Health. 16 of those years as state epidemiologist. I know state and local public health pretty well. We've always had that problem of, as a states' rights issue, disease reporting is a states' rights issue. It's not a federal empowered mandate to do that. And so how do you support state and local health departments to do the kind of reporting or the follow-up? And one of the challenges I think that we have now is you can't just suddenly create a national entity to do this. It still is going to require state and local health agencies to be on the ground at the forefront, but we need to bring new resources, new tools. And we know that we do this feast and famine so often with public health. This happened after 9/11. A great deal of resources were put into state and local health departments, and with several years it was gone. You can't build like that. Imagine if the U.S. military were going to create a new aircraft carrier, taking 14 years from blueprints to finally floating on the water. And every year they had to figure out, are we going to get any more funding or not? I mean, that doesn't happen. They fund 14 years worth up front. And so I think one of the challenges in this report really tries to lay out the issues around that very thing of what kind of funding do we need and how. I think the other thing that is, we have to understand public policy and politics. And what I mean by that is that, when I served at the State Health Department of Minnesota, I served 2 Republican governors, 2 Democratic governors, 1 independent candidate. And I also served in the U.S. federal government for the last 6 presidential administrations, including, as Susan noted, I was even a science envoy for the State Department during the Trump administration. And one of the things that was really important is that no one knew my partisan politics. I didn't have it. I had to check it at the door. I was like a private in the Army. And we in public health need to understand how important that is from a credibility standpoint, that basically the things we say and do are not based on politics. That means you stand up to what is not appropriate information sharing, etc., regardless of what party it's from, or if you support something, no matter what party it's from, if it's really in keeping with good public health. And so one of the lessons we learned is we live in this policy world. And, you know, frankly, we shouldn't be the last arbiter of what to do in a community. Basically, if you look at using the school example again, you know, community should have been brought into that. What do you want to do? What these are the data. These are what tell you what's happening. How do you want to handle to teach your children, who many of us wanted to continue to learn, of course, but you want to protect your children. And so I think one of the lessons that came out of this, and we tried to highlight this in the report, is the fact that we need to really be certain that we're involving the community in these decisions. When it's a public health decision, it's going to be challenged. When it's a community decision with major public health input, it has all the much more likelihood of actually being adopted and getting through. And I think that that's a message we lost, and we shouldn't. So we still play a key critical role, but we're not all alone in that regard. I think the other issue is that if I could say anything that I hopefully tried to bring to this pandemic and what I did, is a sense of humility. By God, we had so many curveballs thrown at us, and people weren't wrong when a curveball got thrown from what they said 2 weeks ago or 2 months ago. But now with new information, we did not prepare the public to understand that this would change over time. And we can count on that happening. It's going to change over time. And so forecast that. You know, I always would say when people ask me what's going to happen, well, you know, my crystal ball this morning when I woke up had 5 inches of cake mud on it. It took me a long time to try to get that off, okay? But acknowledge that. What do you think is going to happen? When, where, why? If you and it doesn't mean you have to be wishy-washy. You just lay out, what do I know and not know? And we came off far too often definitive in our answers. Vaccines are a good example. You know, I'd worked with MERS vaccines and understood the challenge of having durable protection with a coronavirus vaccine. So when the original studies came out in December of 2020, showing this incredibly high level of protection against clinical disease with both the Pfizer and Moderna vaccines, you know, there was public health euphoria. We got it, 2 and done. It's like measles vaccine, we're done. Well, you know, by April of 2021, we started to see the breakthroughs. And you recall that Provincetown in July of 2021, Provincetown, Massachusetts, was where the big festival was held, where we saw all these vaccinated people develop COVID. And all of a sudden, the vaccines, you know, people wait, what's going on here? But even more importantly, CDC had just said a month before, you no longer have to wear your mask anymore, okay? And now they're saying, oh, put it back on. Well, the public felt whipsawed by that. They didn't understand that, in fact, we should have said from the beginning, these vaccines are safe as we know, as they've been used. Number two, these data based on 2 months of follow-up are pretty darn effective. But you know what? Come back and talk to me in 3 months or 4 months, and I'll come talk to you. And then we can understand what it is that these vaccines really did or didn't do. Now, let me just be really clear. These are really good vaccines, but they're not great at all. We now know that durability is limited. There's a vision study that just came out from CDC recently, even looking at the bivalent booster dose, is that from time of vaccination to 4 months, protection against hospitalization drops dramatically, more than 60-some% to less than 20% against hospitalization. Now, that means your boosters are going to be required and necessary for some time. But the point of it is, again, I think if there was any message we should learn is how to be flexible in our messaging, how to basically say what we know and what we don't know, and what we're going to do to find out what we need to know. So this report also tries to highlight that, the uncertainty. And it doesn't point fingers as such. It basically says we're all in this together. And as I said earlier, that's why I feel somewhat reluctant to even share this presentation with you, because you're all experts too. You were there. You saw it firsthand. You experienced it. So I think, Susan, with that, I will just close and offer to take any questions or comments. I welcome questions and comments. And one of the other things I'll tell you, being an old crusty professor now, the older I get, the more vulnerable I am to learning. So I look forward to your comments.
So if you have questions, please raise your hand or put your questions in the chat. I can start and then people can jump into the conversation.
Please.
Or we can just go right to Scott Becker.
So thank you, Dr. Osterholm. It's great to see you. Thank you for the comments. And I really also want to thank you for being an old crusty professor. You were learning a lot during the pandemic, and you were listening a lot to people on the ground in the field. You weren't just a talking head. So I really wanted to publicly thank you for your engagement and your advocacy. And I think it's actually more critical now than ever before. I think we're entering a time that, Susan, prepared us a little bit with what may be coming with budget wise and whatnot. It's going to be awful. And I think resilience is going to be really important. And sticking together, but communicating it is really important. The work, the crisis group's work was fantastic. I hope that you're right, that we can educate policymakers, because we're committed to it. We got to think about doing it in different ways because we didn't succeed. But thank you for everything.
Well, thank you. Well, first of all, I have a disclosure to make here. Scott happens to be a dear friend and someone who I have hold in high regard. And we've worked together now for what seems like 100 years. So you can take those wonderfully biased comments you said about me in that regard. But thank you, Scott. And I think your work was equally very important. And during the time of the testing challenges we had with COVID, your organization was singularly, absolutely critical in helping to get communities through the testing issues and even to raise many of the scientific issues that we raised about the utility of these lateral flow tests, et cetera, et cetera. So thank you. Let me give you an example, though, I think of one of the areas that I'm working on right now, which I feel like I'm trying to swim up Niagara Falls with 10-pound weights on my ankles. And that is the fact that right now there's a fair amount of euphoria again, excitement about NextGen, this new Biden activity for the next 18 months to invest $5 billion into vaccine research as well as to enhance drug discovery. And I think that this is dangerous, which some people say, what? And I say it's dangerous, not because we don't need the resources. It's not that we don't need these better vaccines and drugs. But again, we're setting ourselves up for policy failure, because if you're on the Hill and you look at a group that just got $5 billion for 18 months, and suddenly they don't have an answer at the end of it, well, what the hell am I going to give any more money for? Why? We need to convince policymakers, just like the example I used a moment ago with the aircraft carrier. If you go to our website, we actually have the vaccine roadmaps put together for both influenza and coronaviruses that are actually the combination of more than 50 experts in each of those different disease areas, laying out what's going to be necessary to get to new and game-changing vaccines. And they're not going to happen overnight. I don't care how much money you put into it. It's going to take some time. And in fact, each of the roadmaps lay out more than 8 years worth of work for which we have measurable outcomes. And when do we get this milestone? Then we can move to another milestone. And so I think the challenge I see right now is helping people realize this was not the big one. I mean, people don't want to hear that from me, but imagine the following. Remember with SARS and MERS, the case fatality rates were 15 to 35%, but they were not nearly as infectious as was SARS-CoV-2, which only had a case fatality rate of about 0.5%. And I can tell you, working with my colleagues in the coronavirus world, there is nothing, simply nothing, to prevent this virus eventually one day to be a combination of high pathogenicity virulence and high transmissibility. Imagine what it would have been like if we had just gone through an experience with a virus that was killing 25 to 35% of the people and was as infectious as SARS-CoV-2. Or if it was like 1918 influenza virus. So what we need to do right now is sell our governments and our leaders on the need for ongoing day in and day out support for vaccine and drug research, for public health infrastructure, and it can't be this feast and famine. And if it is, we're going to start out the next pandemic in worse shape than we started the last one, because we won't have much, and we're going to have also lost the faith of much of the public, which we have to gain back. And so I really am concerned about that. And one of the priorities for me, at least, is to continue to push on why we have to have long-term solutions here, and don't count on just, oh boy, it feels good to get $5 billion for 18 months. It isn't going to do it.
Scott, we will now
Sure.
turn to you. And
Yeah,
then Janet, I see your hands raised as well.
Great. I mean, thank you, Michael, for your long-term commitment in this area. You were a great beacon during the pandemic. I was watching on every show that you were on.
Thank you.
And also I say that because your clarion call for what we need to do with governments and otherwise, we were engaged once, you may recall, was 2010 in Doha.
Yep.
With the World Economic Forum. And I remember you speaking on the pandemic piece. I mean, you already had written about this many times. Peter Piot on, HIV, and I was trying to get the world on NCDs. And at the end, the business folks said, oh, we're all going to die of something anyway, invest in other stuff. Something like that. I'm truncating, of course.
Yeah, no, you're right. I remember that.
Yeah. So, I mean, are these the kind of things, as you sort of even said at the outset here, the unwritten pieces that didn't get published, your perspectives piece, these kind of meetings that were there, you've had probably millions more.
Yeah.
That we can highlight more and then figure out a way, how do we get the whole of society approach? I'm working on this business partner roundtables, and we had a meeting yesterday, and we had this nature 385 experts, come up with a consensus piece. But one person has said, right, it's the road not traveled. And I think that's kind of where we're headed, unless we all drum this up beyond our usual audiences. So how do you propose maybe we kind of do that in other places? We also have these failures, if I can call them that, or the movement.
Well, first of all, thank you again for your leadership and activities for this. You've seen this for several decades. Pandemics were not a new phenomenon for you, right, in the sense of the discussions. I think several things here that are really important is we have to understand what are the points of real opportunity here, and they're not the traditional points. For example, I'm writing a new book about lessons learned from this pandemic that we should look to for the future. And one of the key chapters is on economics. And we have interviewed many of the, Federal Reserve Bank, to you name the people there that went, oh my God, look how much this thing cost us. And what would it have been like is if it had an insurance policy that was already in place that could have limited the impact that this had. And, we may have unnatural friends or colleagues in disciplines like economics that come back to say, wait a minute, this is actually worth a lot to invest in this. And, we don't have any problem doing that with our Defense Department all the time. And I'm not trying to take a penny away from the Defense Department. I'm merely saying we have got to understand, as a national strategic and tactical priority, we have got to be in a better place ourselves. So imagine if we had a coronavirus vaccine that had wide breadth protection with durability over time, that you could actually give now and for 10 years have sizable protection against a new emerging coronavirus, or at the very least, it was immediately available at the beginning of the pandemic and you can move it quickly. Think of what that would save. And the same thing is true with influenza. Our influenza virus vaccines, we still have vaccines that if we get 50% protection against medically attended influenza in a given year, that's good. In some years, it's zero. Well, the pandemic's no different. So again, we need to invest in that. And I think we're not going to find our support necessarily from a lot of the standard locations, the medical community, which you would think they should be more involved. I think it's going to be these partners like the economic issues, even strategic defense. I can tell you the Defense Department saw this as potentially being a major global disruptor. And, the idea of even what happened in Ukraine, how much it falls on the back of what happened after the pandemic emerged. And so I think that's where the support's going to come from, to say if we can limit, if even possibly in a dream world, take the next pandemic off the table, boy, wouldn't that be something? And I think that's where public health has to be prepared to engage in that regard.
Thanks.
We have Janet and then Lisa Simpson, and then there's one more question in the chat from Heather Fitzpatrick that will come up.
Thanks so much, Susan. And Dr. Osterholm, it's just wonderful to hear you in this setting. I think you have benefited all of us in so many ways. And I just really want to thank you for that. And thank you for your real recognition and support of public health and state and local public health. I think you were able to continue to champion that in ways that many just almost pushed to the wayside during this response. And so really want to thank you for that. My question is really about your comments on this boom and bust funding. And I think we've recognized that for a long time in public health, but I don't know that we've cracked how to talk about it in a way that leads to sustained, meaningful funding. And I personally feel right now more worried than I have ever been, with not just that we were expecting boom and bust, but at a time where we desperately still need funding. Money that was appropriated to public health has now actually been taken back.
Yep.
And none of us have ever seen that in our lifetimes, just like none of us had seen a pandemic at this level. And so I'm just, wondering if you could share with us a little bit about how can we start to think about and talk about this differently, especially knowing that, I personally feel like we're maybe in the worst place that we have ever been to be able to talk about that story. And then my other question is really more on the science side. And I mean, the pandemic has been terrible, but just like you pointed out, it could have been so much worse. I mean, look, children were largely unimpacted. Imagine if we'd had the same scenario, but that it had really been impacting children and young people. And what would that have been? In this situation, we almost saw pushback on the government, but we didn't see this like fear and terror that we saw, even with one Ebola case amongst the public. And so, and this virus could change. I mean, we've seen influenza be severe in different age groups, and there's no reason why this one couldn't do something different. And it's still, we're seeing so much transmission. It's ripe for mutations. And so how do we really also talk about that in a way where it's most people are fatigued to even hear the conversation?
Well, first of all, thank you again for your very kind comments. And again, in a matter of disclosure, I am a full-fledged member yet of CSTE, one of the most important positions I've ever held in my life when I was president of CST in the 1990s. So I appreciate that. And I think that, thank God you were there. And Janet and I had many conversations during the pandemic that were incredibly helpful and enlightening to me. In terms of the boom bust kind of issues, some of us are continuing to try to make that case why we have to be better prepared for the future. And again, trying to find unnatural alliances. For example, as I said, I've had conversations, much more than conversations, actual back and forth a lot with people at the Federal Reserve Bank and members of the actual Federal Reserve. In areas such as defense, I've had some very high level and ongoing efforts with the Defense Department. I think it's going to be more of that kind of unnatural previous kind of experiences that we're going to have to use to make the case why this is so important. I think the medical community in of itself has got its own problems. I mean, our medical care system in this country, a disease care system, is severely broken. And I think this pandemic only emphasized that. I don't see that a partnership right now. While we need to work with them closely in terms of everyday reporting, et cetera, and what we do without population-based outcomes, they're not in a position to advocate for us. They're having a hard time advocating for themselves right now. And I think that this is a very, very huge issue. So I think Janet is going to continue to be trying to hit home on the insurance policy approach of public health. We offer something that can make life better. We're all going to die. Every one of us is going to die on this screen. And God bless whoever's the last one, shut the lights out. Okay, thank you. And we're all going to have a top 10 causes of death. So if we eliminate these 10, now we'll have 10 new ones. I'm not sure they'll be any better than the 10 we got now. But I think we can all agree living long, productive, pain-free lives. Isn't that the goal? That's what stimulates the economy. That's what stimulates healthy populations, not just from a health standpoint, physical health, but mental health, etc. So I think what we want to do is say, you know, in public health, we try to attack those things that kill people early or make them disabled or create crises in our communities, which disrupt everyday activity. And that's what our job is. We're not sitting here trying to prevent death. We're trying to make good deaths happen. And that may sound somewhat strange. At the same time, people can start to relate to that. And I think that's where we're at. Do I think it's a perfect answer? No. As I'm writing this book right now, I'm trying to come up with some of these very answers. And I think, though, that it's what struck home to me so far has been how little we've used potential allies who could really help us support at a congressional level. And we've got to get the issues worked out on the state-federal relationship. I mean, CSTE has done a tremendous amount trying to lay out what might the blueprint look like for disease surveillance of the future in the states' rights issue. And you just can't have a federal law that suddenly says, okay, this is it. This is how it'll be done. So, Janet, I continue to look to you for advice on this issue. So I feel kind of stupid giving you advice. But I think at this point, this is really a very, very key piece going forward. If we don't deal with this in a much more thoughtful and organized manner, we are going to be in the deep soup again come the next pandemic. And we don't even have a full pandemic. Imagine if we, had any number of infectious agents start out and cause a big crisis, not a pandemic nature, but still, look what Mpox did, etc. Thank you.
I guess I'll ask my
Yes,
question
Lisa.
next.
Turn to you next.
Dr. Osterholm, I'm Lisa Simpson. We haven't met. I'm the president and CEO of Academy Health, the National Association for Health Services Research. And, to add my voice and thanks to all that has been said already, and I could go on, but I want to ask you a question, given your experience, not just in the last 3 years, that, those of us, safe at home, watching this all unfold, were in addition shocked and outraged at the attacks on experts like so many and public health leaders at the local, state level, nationally. And I sort of wondered, I'm going to assume, but please disabuse me, that you experienced some of that. And to bring more sort of action oriented, how do we try to mitigate that or support leaders, protect them, train them for this type of reaction from society? I know you touched about some of what we could have done better, and there's always that learning, but I think we're always going to experience some of that level of personalization of unwelcome information from the public. So I'd love your reflections on that.
Well, first of all, thank you. This is a very important question, and I think you nailed it. For me, it was a situation where, I'll have to admit, if all the years I've been in this business, and some know me to be not afraid of controversy, I'd never, ever once had a death threat until COVID, of which then I too received them with some regularity. Fortunately, I had the law enforcement contacts that screened them, etc. None of them really hit home to me, however, until I got the first one that said, I know where your kids and grandkids live. Should give you a reason why you should shut your goddamn mouth. You know, that type of situation is so sobering. And I don't know you can train for that. Part of the challenge is that, this is a world where violence is such as we all know has become a norm for how people act or react. And, we have to address it. Peter Hotez is one of my dearest friends. We talk virtually almost every day. And you know what he's been going through the past week and a half with that issue there. So I think the recognition that this is there is important. Now, I actually have been told by some of my colleagues, don't talk about that very much because we'll scare students off from coming to schools of public health. And my answer is, well, we owe that to them to be fully transparent about what our jobs might look like. Now, grant you, many public health people took a great deal of abuse during the pandemic, but I can't say that it was life-threatening abuse. It wasn't where you were really concerned with somebody who might be mentally unstable, come find you where you're at and end it. Not all of us can afford to have security details like some of our national figures have had. But I think at the same time, this is an area where we have to, at our state and local health agencies and at our schools of public health, really have the discussions of, what do you do for awareness? How are you aware of what happens? And, also just prepare people to, this is what's going to happen. And you can't see yourself as the problem. You can't see yourself as the reason why this is happening. So you blame yourself. You have to see this is the kind of society we live in today. And, frankly, my job, as you all know, just like your job is whether that person says they hate me or not. My job is to hope they don't get infected and die from the infection. And, I personally went through that. I actually had a dear friend who refused to get vaccinated for reasons I still can't understand, who subsequently died from COVID. That was a very challenging situation to see that kind of thing happen. But let me leave it with some perspective. A couple of weeks ago, I was going down an elevator at the University of Minnesota to go to an underground tunnel to my building, and I had my N95 on. And I get in, and there's this little old lady who I say this with great respect, must be about 85, tiny, in the corner of the elevator. And she looked at me and she said, "Do I know you?" And I said, "Well, no, I don't think so, ma'am." She said, "What do you do here?" I said, "Well, I'm a professor here." She said, "What do you teach?" And I said, "Infectious diseases." And then she took a step back into the corner even further, which I didn't think there was any more room to do that. And just then the door opens and she slides her back along the wall to the open door. And then she turns on, looks at me and says, "Would you just shut up? Stop talking. Just shut up." And I thanked her, "Have a nice day," and away she went. That's the world that none of us could have imagined we'd live in, where our job has been to try to help people just like her. And I think that that's really a really very important point. Just don't give up.
Heather, I know you also had a question.
Yeah, just quickly, thanks so much, Dr. Osterholm, and thanks to all the questions that have already come up. I've really appreciated listening. My name is Heather. I'm on staff here at the American Academy of Pediatrics, and we're about to go through the similar process of sort of just examining what did our members experience, what did the kids that they cared for experience during COVID. And I guess I wondered if you had any kind of questions. I know you mentioned healthcare a couple of times. Any questions that you would recommend us asking our members to really learn the most of what we can learn from our experience and hopefully be better prepared for next time. So just.
Yeah, no, well, first of all, I think that being in the care delivery segment of the world in terms of pediatrics is always challenging. Every outbreak I've ever worked on, when kids are involved and there are serious health consequences, a lot of rational reasoning goes out the window with those who are there. As parents who, I want my kid to go to school every day, but I want zero risk. Okay, give me both right now. And I think that one of the challenges we have, and by the way, I have to thank the Academy for the kind of surveillance work you did on pediatric related COVID cases. It was extremely helpful. We got a lot from you. I think that what we have to do is ask ourselves, how do we keep the frontline family practitioners, pediatricians, et cetera, informed in a way to say, like, for example, what I gave you about what happened with schools. The first year was very different than year 2 and 3. And how do we help incorporate that into risk and management decisions? Great debates that occurred. Should kids get the vaccine or not? What's the risk of getting the vaccine versus not? What does the vaccine hold? So I think just having those kinds of discussions about what worked or didn't work, or what could you have used for information? How could it have worked better? You know, I fortunately had a pretty good inroad on the pediatric side of the house. My daughter happens to be the medical director of the NICU at the University of Minnesota. So I typically had a pretty good, finger in the air about what was going on in pediatrics. And I think one of the challenges they had often was just trying to stay current and rapidly changing information so that they could then deal with parents. The other thing you have to do is assure them, the practitioners, that you will not have all the information. Parents will have more questions, and they will sometimes almost irrationally reach out to you to fix everything that you can't. And I see that differently than adults. It's not an adult to an adult that does that, but it's when your kids are involved. As I once heard somebody say as they sat at a microphone with a cigarette hanging out of their mouth, any risk for kids is too great of a risk for my child.
Thank you so much.
Thank you.
And on that note.
Well, thank you.
Dr.
I'm honored
Osterholm.
to have been here with so many dear friends and colleagues. Okay, I feel like it was a family reunion. Thank you. I appreciate it.
And that is actually what we're going for, which is making sure that we all know what we're all doing so that we can do everything to avoid and learn from the lessons that we've had. And so having these relationships is really helpful. But thank you, Dr. Osterholm, for everything that you've done in the past and that sharing your time with us today. We just have a few minutes left, so I think that we might have some internal announcements, and if there's anything that you want to share, please feel free. I will turn it over to Angie, who I think has some updates about the Alliance.
Hey everybody, great discussion. Just a couple updates just to let you all know that we are still working on what we really just talked about today. What have we learned from the past about kind of where we are with our public health system and where are we trying to go? And so after all the discussions we've had with you all, looking at the recommendations, having, virtual sessions and others, we are still moving towards figuring out where we can go to help take action, knowing that the Alliance may play many different roles. Someplace we might help be a leader, we may help be a convener, we may help just to amplify what we've heard otherwise. But what we've heard is 5 areas that really need our attention. And by our attention, I mean all of ours, learning from what's going on out there, are really how can we have these discussions about communicating about public health, our value, and why our public health system needs to be the robust, equitable system we do. How can we also advocate for that? How we get involved in that political space that we were just talking about in a way that's positive and helps us move forward. How do we continue that focus on equity and making sure that we're lifting that up as a goal for where we need to go in our system? Also involving communities. As you all know, our colleagues at Shared Cause have been leading with many of you all discussions about models where communities have been really a greater part of this. And so make some of those discussions, as Mike just mentioned, how can we have support to lift up community-based coalitions and others? And then finally, how do we make sure that the funding out there, the workforce, that we're really advocating for that strong workforce that we need, making sure that it is innovative and broad. And so I know there are many groups out there doing this work with all of you all, hopefully can figure out what that right role is for us, but there are areas that we've heard together, a collective group like ours needs to get started. So we're going to start some kind of smaller discussions. We'll come back to you all with ideas on where work groups would go. But if these are areas that you all would like to be part of, feel free to reach out to us at alliance@apha.org or give me a call. We'll be happy to have you all as part of it and really look forward to seeing hopefully where we can go to kind of lift up this conversation and continue this work as we've been hearing about so that we really start to figure out how public health gets that attention, the credibility, and hopefully becomes that insurance policy that people see that is so important to our nation. That was my quick update, and stay tuned for future meetings. Others, as we mentioned, are welcome to put things in the chat room or lift your hands. I also know Sarah Ivy has volunteered to give a quick update as to where we are with Fern, if we're ready for that.
I'm happy to jump in, but noting that we have 5 minutes left and people may have questions, I wouldn't want to take the time. What do you think, Angie?
About super quick, and we'll come back to you next month.
That sounds good. Well, hi, everybody. You may remember me. I'm Sarah Ivy from the Institute for People, Place, and Possibility and the Community Commons team. I am part of the team that's been helping to build and promote Fern, the Public Health and Equity Resource Navigator, which is a project of APHA and the Alliance. We had the great opportunity last month to speak at, actually 2 weeks ago, still this month, at Grantmakers in Health. That conversation was really about how Fern is helping to build momentum for public health and equity. So we wanted to just quickly share a little bit about what was presented there, so you can get a flavor for where we are today. Oops, I don't have sharing access, but I'll just really quickly note that some of the themes that came up was included promoting networked learning. One example of how I have screen sharing now. Fantastic. And if you're so inclined, you can feel free to use those QR codes up in the corner to navigate to some of these example pages. But we really tailored our discussion to some of the more recent features and projects that have been built out on Fern. So one way Fern is helping to build momentum is by promoting networked learning. A great example of this is what we did in creating the National Public Health Week toolkit on Fern, which shared the theme, key information, and got a little bit deeper into some of those daily themes and topics of interest during National Public Health Week. Fern has also been helping to implement an advocacy agenda. You all have probably seen the fantastic toolkit that Angie, Raya, and team have been putting together and sharing, the Protecting Public Health Authority and Advocacy Toolkit. We created a digital version in the last couple of months that is a home for those resources as we continue to build them. This can be shared with anybody, so feel free to share the link. Another way is that Fern, as you all know very well, is an online home for our collaboration. We're seeing this proven out in a couple of projects. So our focus at the moment is helping to build a content library for Public Health AmeriCorps, as well as creating and keeping updated what we're calling a guide to success for Public Health AmeriCorps members at the APHA annual conference and expo this year, and as they engage in that collaboration over the coming year. We're also working on building a learning journey for newcomers to public health that will be for anybody. So we look forward to sharing that with you later this year. You all have gotten to see the map, and I think probably all of your organizations are on there. Of course, we continue to build this. This is an approach to sustainable field building. We gave the example during Grantmakers in Health of Made to Save, which worked with us as they were sunsetting to map their partners, and it was a way to infuse the Public Health and Equity Resource Navigator and future efforts with that network intelligence that they grew during the course of their initiative. This is the kind of work that we'd love to take on. So if anybody might be able to benefit from some network mapping as part of their field building, please do reach out. And one thing that we also wanted to highlight for everybody at Grantmakers in Health is that Fern has ready built capacity. So it is yours, it belongs to all of us, and we're building it collaboratively. And that means that we have not only the technical assets there in place to build great digital content that can promote health and equity, But we are also able to deploy our team and the standards that we've created for developing that data really readily. So these projects can move quite quickly, as the Vaccinate Your Family portal did with the help of their intern. I look forward to sharing more next month. I hit the 12 o'clock mark here on the West Coast. It was great to be with you all. Please reach out to me, Sarah, at i-p3.org, if you have any questions, and look forward to working on some future content with you all.
Thank you, Sarah and Erin, for the links in the chat. Thanks, Angie, for the update. And I think that we're now a couple minutes over. So thanks to all of you for participating today. We look forward to seeing you next month at the next Alliance meeting. And in between, please feel free to reach out if you have any questions or there's anything we can do to help.